causes for hydrocephalus, with obstruction secondary to adhesions and inflammation. Other causes include congenital webs, Chiari and Dandy-Walker malformations, endoplasms such as colloid cysts, and ependymomas and medulloblastomas, depending on which area they're more frequently found in. So the image on the radiographic right shows a T2 FLAIR image showing dilated ventricles with periventricular hyperdensities relating to transependymal seepage of the CSF. And the image on the radiographic left shows a sagittal T2 image showing convex bowing of the corpus callosum and tonsillar ectopia. So the structure T labeled in the image shows an ependymoma in the fourth ventricle, causing the obstruction. The image on the radiographic right shows dilated third ventricle on T2-weighted imaging, and while the image on the radiographic left shows dilated temporal horns, which can be seen in hydrocephalus. So ex vacuo ventriculomegaly is enlarged ventricular system secondary to parenchymal atrophy. Both the ventricles and sulci will appear prominent in this entity, while in hydrocephalus it could present as only the former. Both the third ventricle and the temporal horns are surrounded by tissue which is not significantly atrophied, so these won't appear dilated typically in ex vacuo ventriculomegaly. So this is a CT scan showing encephalomasic changes on the right, secondary to a stroke, associated dilatation of the ipsilateral lateral ventricle as an example of ex vacuo dilatation. Moving on to normal pressure hydrocephalus. This chronic hydrocephalus from an incomplete CSF block, usually from prior subarachnoid hemorrhage or infection. So classic triad for this disease is dementia, gait disturbance, and urinary incontinence. Patient could present with normal CSF pressure but with a gradient between the structures. This diagnosis is not purely a radiographic diagnosis. We need the clinical information to be able to come up with this diagnosis. Finally, moving to neurodegenerative disorders, we have Alzheimer's disease, which is the most common neurodegenerative disease and cause of dementia. The cause so far is still unknown, but histopathologic findings show neuritic plaques and neurofibrillary tangles. On imaging, this will appear as diffuse cerebral atrophy with predilection of or in the hippocampal formation, temporal lobes, and parietotemporal cortices, which can present as enlargement of the temporal horns, the suprasellar cisterns, and sylvian fissures. PET imaging is actually useful to assess therapeutic response earlier than imaging, since we can see the metabolic changes earlier than the structural changes. The most sensitive measure for the volumetry to detect atrophy is to do volumetry of the mesial temporal lobe, which is actually what we take the volume for when we do dementia protocols for our patients. So the image on the radiographic right shows a coronal T2 FLAIR image showing atrophy of the temporal lobe with prominent sulci, and the image on the radiographic left shows an axial T2 image showing atrophy of the parietal lobe. These are the lobes usually affected in Alzheimer's disease. So for Parkinson disease, it's the most common basal ganglia disorder. Clinically, the patients present with tremors, vascular rigidity, and loss of postural reflexes. So MR findings for these patients show a loss of high signal intensity in the pars compacta between the pars reticularis and the red nuclei on T2 weighted imaging. But this finding is usually only seen in severe cases. So for Parkinson's disease, it usually presents with the loss of the swallowtail sign, which is a most promising diagnostic sign for Parkinson's disease. So let's just take note that the presence of the swallowtail sign is actually the normal here. The swallowtail sign just describes the imaging finding that was described earlier. Yung loss of high signal intensity of pars compacta between the pars reticularis and red nuclei. That is what that is what is seen when there's loss of the swallowtail sign. So the image on the radiographic right shows a SWE axial image with the normal swallowtail sign, while the image on the radiographic left is another SWE axial image showing the loss of the normal swallowtail sign, which is seen again in Parkinson's disease. So for Huntington disease, which is a progressive hereditary disorder which usually occurs in the fourth and fifth decades of life. So movement disorder, dementia, and emotional disturbances are usually the clinical findings. And imaging-wise, it presents as diffuse cortical atrophy, most severely affecting the caudate and putamen, which can present as enlarged frontal horns with heart-shaped configuration on coronal views. So the image on the radiographic right shows an axial T2 image showing the caudate head atrophy, pointed in blue, and atrophy and hyperintensity of the putamen, pointed by the red arrow. The image on the radiographic left shows a coronal T1 image showing caudate atrophy with apparent heart-shaped configuration of the ventricles. So for Wilson disease, or hepatolenticular, which is hepatolenticular degeneration, which is an inborn error, Wilson disease is an inborn error of copper metabolism. The patients also present with hepatic cirrhosis and degeneration of the basal ganglia. Clinically, these present as with dystonia, tremor, rigidity, and Kayser-Fleischer rings. And imaging-wise, it appears as diffuse atrophy with minimal abnormality in the deep gray and white matter on MR imaging. So this is a representative image for a patient with Wilson disease. This is a T2 FLAIR axial image showing hyperintensity in the basal ganglia and thalami. So for other basal ganglia abnormalities, these include carbon monoxide poisoning, which usually involves the globus pallidus, methanol, excessive methanol, which affects the putamen, West Nile virus, which is due to disease transmitted by mosquitoes, and Creutzfeldt-Jakob disease, which occurs in ingestion of beef products. These present usually as T1 shortening within the basal ganglia. Just moving on to questions, which is the most common leukodystrophy? So among these choices, the answer would be metachromatic leukodystrophy. For the second question, which of these will show a giant NAA peak? The answer for which is Canavan disease. This is actually pathognomonic finding for this disease on MR spectroscopy. For the third question, which is the cause of these is the cause of non-communicating hydrocephalus, the answer of which would be a colloid cyst in the third ventricle. Well, the other three choices would present as a communicating hydrocephalus. And last question, which of these will present as heart-shaped configuration of the ventricles on coronal views? The answer for which is Huntington disease. For my happy slide, I'd like to say that in order for us to succeed, we must first believe that we can actually do it. So that ends my presentation. Thank you for listening.